if you've been keeping an eye out on some of the trends in MedEd, you might have noticed that there are more and more interdisciplinary programs that attempt to intertwine the arts, humanities, and social justice into philosophies of medical practice. It's become very, very popular. More and more undergraduate programs are popping up. More and more graduate certificates are popping up. There are actually whole huge spreadsheets of these programs that combine the methodologies of arts and humanities. And so I comment on that because while this may seem very trendy now, this is historically informed. This has been around for a while. So apropos of this historically informed relationship between the arts and humanities and medicine, we wanted to take a second just to show you a couple of the famous museums, anatomical collections in Europe. So these two are two examples among many of the Hunterian Museum in Glasgow, Scotland, and the Specula in Florence, Italy. So these two examples do an interesting job of conflating the history of anatomy with the history of the artistic endeavor. Those models that you see on the right-hand picture at the Specula are made of wax. Wax has been used to teach anatomy for a very long time. And the models at the Specula in Italy are just intricately created and still used. You know, if you're just looking at a visual analysis from like the cell layers of different organs, the wax models actually still have relevance. They're really quite powerful. So it's interesting to see how the roots of this continue to kind of repeat themselves in various ways. This historically, I wanted to give a shout out to the book Objectivity by Lorraine Daston and Peter Gallison. We're not saying anything new by pointing out these relationships. There are whole fields of studies that are invested in thinking through this historically contingent relationship of art and medicine. Objectivity is a significant contribution to the field of the history of medicine and science and technology studies. And this book discusses the significant efforts made by way of artistic intervention to create a standard representation of normal versus pathological bodies out of composite specimens. So in other words, reaching to find what is a standard of normal was something that was performed by artists more than it was by anatomists for a time. It was a combination of both, but it was the artist's hands who had to create this composite version underneath the physician's guidance. Just by way of an interesting example of how art and medicine have this dialectical relationship, we wanted to share two images side by side. We have our cover image, which is it's a painting called Cauda Equina by an artist named Riva Lair, who she herself is disabled. She has spina bifida. And as you could see, you know, right at the point where her spine did not correctly fuse, she has this glowing pelvis and this glowing horse skeleton behind her. What's interesting about this image, whether this was by intent or by accident, is that it speaks to one of the old anatomical images, again, creating a standard of ideal body type and normal. John Barclay's 1829 skeletal anatomical textbook basically framed the ideal masculine skeleton as comparable to a horse's skeleton with broad hips, broad shoulders, right? And just a lot of strength. And the ideal female skeleton is compared to an ostrich. Tiny ribs, wide hips, long neck, and a tiny little brain, right? And while we like to think that these things don't haunt us in culture to some extent or other, they kind of do. So we just wanted to show that comparison again, just to kind of give you one example of how this dialectical memory tends to repeat itself. Whereas, and just to sort of give a footnote here, we're not attempting to claim by any stretch of the imagination that European medicine or Western medicine in writ large is more valid or important than the worldwide contributions to the history of current medical practice and the history of medicine and art. European medicine had the biggest influence on US medicine, so that's why some of our comments tend to focus on that. But by way of clarification to the scope of our argument, it's just to say that this is our focus, but not, there are more conversations to be had. So whereas the history of medicine and anatomical study in Europe was more artistically contingent, in the US, interestingly, our development of medicine as a pathological science didn't happen until fairly late in the game. We did not, in the US, have a regular steady supply of cadavers until the Civil War. And at that point, right, our anatomical libraries really developed. From the Civil War came the Army Medical Museum, which ran from 1862 until 1969, when it closed and the library materials were dispersed throughout Washington, D.C. But it's interesting to think that even though now there's this big focus stateside in combining medicine and art and humanities, we're a little late to the game here, right? Across the ocean, we have this relationship of medicine and art and how those two dialectically informed one another. In the US, our pathological focus was derived from war. So it's nice that we're now coming back to this more artistic bend, but it's worth keeping that in our back pockets, that this has been around for a while.
So now we'll tell you a little bit about how we specifically in our program are bringing this magic back to the table, bringing some of the humanities back into the practice with our curriculum, the compassionate practice. The first thing to note is that it's interdisciplinary at its core. So we're going to spend some time talking a little bit more about some of these theater pedagogies in a minute. I'm sure that many of you have been moved by a piece of theater or film that you've seen, and it's some of those techniques that make theater come to life that we are borrowing to work with our students in building connection with their patients and their communities. But I want to start by talking about empathy. We generally broadly might consider ourselves empathetic people, but depending on the circumstance, our empathy might wane a bit. So this means that it's a malleable thing, and it will depend on who the audience is. Is it for ourselves or is it for someone else? We're often much more capable of being empathetic to someone else than we are to ourselves. And the other thing about empathy is that it's limited in its scope. We tend to think about empathy as like, I'm standing in someone else's shoes, experiencing what they experience. I know what their life is like. And the reality is we can never completely understand someone else's lived experience. And in fact, it's really important to acknowledge that limitation. We can examine someone else's life, and we might even have certain experiences in common that help that empathy feel more profound to us. But there's always some limitation in our ability to know what it's like to be someone else. And so here, we're teaching students a process to examine themselves and to examine others, which also recognizes the space between the self and the other. And then you treat that space with respect and curiosity. The next element is that you have to turn that empathy that you cultivate into action. Otherwise, it remains inert. It remains unfelt by your audience. So we're teaching students, all right, so you've worked on a process to cultivate empathy. What are the things that you need to do to communicate that? What ways of communicating that are appropriate for your audience? What are the things that you actually need to do with your tone of voice, your body, your word choice that will translate that empathy into something meaningful for the receiver? And that hinges on what I was alluding to before, which is the platinum rule. Who here is familiar with the golden rule? All right, most of you. Anybody know the platinum rule?
I know the platinum rule.
Lauren does. Do you want to tell everybody what the platinum rule is?
So if the golden rule is treat someone else how you would want to be treated, The platinum rule is treat someone else how they want to be treated.
Spot on. So the platinum rule is just a socially just spin on the golden rule. It reinforces the autonomy of the other person to dictate how they want to be treated. So it's important to make sure that you're treating someone from their own space of comfort. So where are we getting a lot of these ideas? Konstantin Stanislavski was a seminal Russian theater practitioner at the turn of the 20th century. He co-founded the Moscow Art Theater at the age of 33. And his life's great work was this acting manual called An Actor's Work, in which he outlines this method, the Stanislavski method. What's amazing about Stanislavski is he was the first to really subject both his acting and his directing to a rigorous process of self-analysis and reflection. And what this resulted in was really natural, believable character portrayal. And this was a deviation from some of the standard theater practice at the time, where you saw really bombastic performances that felt entertaining, but not necessarily grounded in reality. So Stanislavski deviated from this form of performance to really dive into what it means to portray characters in a way that was real to the human experience. He emphasized the art of experiencing, which he contrasted to the art of representation. So you can think a lot of times when we talk about the fact that we're going to use acting and theater in medical practice, some physicians are like, but what I do is not pretend, it's real, it's very real. And it really, the reality is in the performance landscape is we spend a lot of time figuring out how to make this connection real. So it's not pretend. We are not performing the character, we are becoming the character. And this was all based in a Stanislavski method, which was finding mechanisms to help uncover who this character was, what made them tick. So as an actor, we would spend time pulling these pieces of the script apart to analyze character, given circumstances and objectives in a search to build connection with each other on stage as well as with the audience. So we've taken this process of character, given circumstance and objective and translated it into a repeatable process to help our students cultivate empathy. The first part of it is really focused on examination of the self, asking 3 core questions that are derivative of these character, given circumstance and objective. Who am I? So we play different roles throughout the day. When this is over, I won't be a presenter. I'm going to be a faculty meeting a student. So that role switches throughout the course of a given day, throughout the course of our lives. We switch roles. Our core who can transition all the time. Where am I coming from it hinges in our given circumstance. So asking this question, this is historical, social, and structural examination. What are these influences that have shaped where I'm coming from, what my perspectives, my worldview, my emotional content? And then what is my goal? What has driven me to be here in this moment, speaking with whoever my audience is? What is it that I'm aiming to achieve? So effective communication really hinges on the student's ability to be self-reflective, be self-aware, learn to emotionally self-regulate so that they can be deliberate about how they're communicating and what they're communicating with patients, communities, with each other. We support this process in our curriculum through a lot of written reflections, which the students complete on a regular basis, as well as other contemplative practices that have them examine their own experiences through a critical lens. But let's look at the other side of the coin. So we do spend a lot of time working with students on this process of self-examination. The second layer of this that's so critical is perspective taking. This is where students reflect on other people's experiences. This is very much like what an actor does when they're doing that character examination I described before. They consider the various identities that this person might occupy, all their who's. They need to pay attention to the structural, social, and emotional content of their patient or the community that they're working in. What is it that this community or this patient wants or desires? How does that align with my own goals? What do I need to shift in order to be responsive and effective in this engagement with this patient or this community? And what this helps to do is help a student remember to occupy a space of inquiry as opposed to a space of expertise, and recognize that while they've got a tremendous amount of medical knowledge and information, they are all of that is contingent on the expertise of the other person, which is the expertise in their own lived experience. So you need each other to have the most effective outcome in patient engagement or in community engagement. We've talked about the Stanislavski method. Another theater methodology I want to introduce, and this is a cornerstone of my own research interests right now, with Lauren's support and encouragement, is the Viewpoints Theory. And this is a technique that was developed in the 70s by a master theater artist and dancer and educator, Mary Overly. It was later adapted by the two renowned directors, Anne Bogart and Tina Landau, and it shifted quite a bit at that time. But it was originally conceived as a method for actors and dancers to explore movement on the stage. It functioned as a medium to think about moving through space and time. And so we used it as actors to practice in investigating nonverbal connections with other actors or with objects on the stage. And it helped facilitate connection with audience, even if there was a fourth wall. This utility of space and time allowed audiences to feel the performance. And often the depth of this kind of examination can really mean the difference between a stellar performance or something that's really lost its luster. It can be a reinvigorating process for performers. And on a personal level, Viewpoints was really instrumental for me when I was living and working in Namibia, providing HIV education and health services, and navigating a new cultural environment, a new physical environment. I leaned back on this technique quite a bit to help myself understand what was going on in these spaces. And space and time functioned very differently in Namibia than it did in Texas, where I grew up, or in Boston, where I lived for years. And spending time paying attention to things like gesture and shape, the duration or tempo of movement allowed me to begin to make sense of how people were communicating differently than I was used to. And these concepts translate into theaters of care pretty seamlessly, in which physicians are operating, and it helps them to understand how nonverbal communication is impacting how they're connecting, whether there's meaning making, and whether it's impacting the care they're providing. So in the classroom, we might have students spend some time initially examining an image of a theater of care, and ask them to consider the spatial relationship between people and objects. How close are the objects to the people that need them? It's set up this way. How close are people standing to each other? How does that impact their ability to do their work? What are the elements of architecture that give us information about the function of this space? We might ask about the duration of movement. For example, how long do you think this person has been standing? Might ask the students to imagine what the tempo is in this room. How quickly are people moving and speaking? And how does that impact the work that they're doing? The kinesthetic response. How are people moving in response to each other in this space? It looks quite crowded. Are they bumping into each other? Are there more people than there need to be? Or is it the right amount of people to get the work done? And then how do they take care of each other kinesthetically to make sure that they're all functioning to make the work happen.
Chase, I have to share with you that just in looking at this picture, I have a kinesthetic response, like an old vestige from when I would just be available in the OR to support patients before they went to sleep, to just go like this, right? Because I see that, and that's my automatic response, is close up into yourself around the sterile field. And I'm sure that others also may have that knee-jerk response too.
We also use viewpoints to examine texts. This is an excerpt from The Use of Force, written by William Carlos Williams, in which we spent time with students, and this is a narrative told in the language of movement, with gesture and spatial relationships and kinesthetic responses being outlined as a way of understanding how the physician is caring for, or in this case, not very well, the patient that they're there to see. So you can see language like opening both hands wide, saying I haven't anything in my hands, asking the child to open up your mouth. I slowly approach the child, so that's tempo. So you can see movement being used to articulate how this physician was communicating with the child that he's caring for.
Well, just in thinking also about how his emotional reality manifests in these movements. So obviously, over Zoom, we had to get creative when we're having conversations about movement. And luckily, this very canonical text is available to us, and we were able to point out a very apt example of viewpoints, which I'm so excited that we're really diving into in our curriculum, because it's a useful framework for students as they reflect both on their emotional realities as well as in their literal physical space in clinic. Yeah.
So those are just two examples with Stanislavski method and the Viewpoints Theory, how we're folding theater pedagogy into the compassionate practice to work with students on their emotional content, their verbal and nonverbal communication, perspective taking, self-awareness.